Hello, and welcome to a new RPTH Research Recap, where we dive a little deeper into the science being published at RPTH. I'm Dr. Yazan Abu Ismail. I'm a classical hematologist and assistant professor of medicine at the University of Utah, and one of RPTH's new social media associate editors. It's my absolute pleasure today to introduce Doctors Scott Waller and Dr. Benjamin Horn, who will be presenting to us about their recent publication with RPTH titled Biomarker Derived Risk Scores Predict Venous Thromboembolism and Major Bleeding Among Patients with COVID-19. Dr. Scott Waller is a professor of medicine at the University of Utah and a professor in research in Intermountain Healthcare and governor of the American College of Physicians Utah chapter. His academic interests include thrombosis medicine and prevention and anticoagulation management, and he is co-chair for the American College of Chest Physicians Clinical Practice Guidelines addressing antithrombotic therapy for venous thromboembolism. His research group was awarded the 2015 CDC Venous Thromboembolism Prevention Challenge Award. Dr. Benjamin Horn is a chronic disease epidemiologist in the Intermountain Medical Center Heart Institute here in Salt Lake City, and a clinical associate professor affiliated in the Division of Cardiovascular Medicine at Stanford University. He's trained in genetic epidemiology at the University of Utah and holds masters in public health and biostatistics. He is a fellow in the American Heart Association and the American College of Cardiology. Dr. Waller and Dr. Horn, it's an absolute pleasure to have you. And you'll be presenting to us about your research, followed by a Q&A discussion. And for those of you joining us live on Twitter, Facebook, or YouTube, feel free to leave questions in the comment section below for the discussion afterwards. I will hand it over to you, and thank you again for joining us.
Well, Dr. Abu Ismail, thank you so much for that kind introduction, and thanks to you and RPTH for the opportunity to share a little bit about our recent work surrounding biomarkers and predictiveness of venous thromboembolism among patients with COVID-19. These represent our disclosures. And I guess I would just start by saying that I deliberately included that photo that you see at the bottom there of our Intermountain Medical Center here in Murray, Utah, because so much of the work that we do is a function of the legwork that's formerly been done looking at electronic clinical decision support and the robust electronic health record that has been developed over the years. So a nod to those that have come before us. What Dr. Horn and I'd like to do over the next few minutes is just kind of walk you through some of the salient aspects of our recent RPTH publication surrounding biomarkers predictiveness in venous thromboembolism among patients with COVID-19 pneumonia. So broad understanding exists that COVID is associated with increasing the risk of thrombosis, and varying mechanisms have been described, including COVID-specific coagulopathy, perhaps attributable to neutrophil extracellular traps, the presence of transient lupus anticoagulants, and distressed leukocyte adhesion molecules and the like in an H1N1 type process. And importantly, clinically, what we end up seeing is that patients that are hospitalized with COVID-19 and even a subset that are ambulatory appear to be at an increased risk for thromboembolism. And that rate varies in the literature, but even up to a third of patients appear to be affected. When we think about COVID-19 and pneumonia and markers for disease, early on, D-dimer was described as perhaps predictive of risk of severity of illness. And it's also been suggested as a possible predictor for venous thromboembolism. And so in approaching this work, we were mindful of leveraging the tools that we had to try to think about predicting risk of thrombosis. Lastly, we want to be mindful whenever we apply thromboprophylaxis. We know that while it's associated with reducing risk, potential harm exists, including that for bleeding, but also cost. And when we think about systems, why we're inclined to take an approach that optimizes that risk-benefit ratio. So it was really our objective, acknowledging that it's difficult to know precisely which COVID patients might be at greatest risk for thrombosis, to see if we could identify a cohort of patients using a novel risk assessment model who had COVID and then would be at greatest risk to go on to develop thromboembolism. Now, to do so, we looked retrospectively at patients that tested positive within our large healthcare system. Intermountain Healthcare is presently a 23-hospital healthcare system that's aligned in the same electronic health record. And so we had the ability to look at lots of patients and their clinical outcomes. And then we wanted to see if this novel risk score that we had formerly described might be predictive of associated venous thromboembolism and also major bleeding, which I'll speak about a little more tangentially. Perhaps the most exciting part of this talk is coming right now, and that is Dr. Horn, who's going to talk us through a little bit the work that he has really pioneered surrounding the derivation of the Intermountain risk score and how that is led to the work that we're discussing today. Dr. Horn?
Thank you, Dr. Waller. Yeah, we began in 2005 looking for a method of predicting future outcomes using common, readily available risk predictors that were dynamic, not comorbidities where once you have it, once you're diagnosed with a condition, you don't lose that diagnosis. And so we looked for laboratory factors that are commonly available, and we settled on the complete blood count and the basic metabolic profile to derive this risk prediction tool for mortality. And it was something that we found, in addition to what you might expect for markers of future outcomes, there were others in these lab panels that were not being utilized even very often in clinical care, such as the red cell distribution width, that were very predictive of future outcomes. And so for thrombosis population, we had considerable experience the last 15 years or so looking at outcomes using these panels and combining them into a risk prediction tool. And so it made a lot of sense to us to, as we were trying to create a score that would be practical and feasible to use for clinicians, that we would go back to this same model, looking at these commonly available laboratory panels where they could be used in the background within an electronic health record to calculate a score without having to burden clinicians with the actual calculation, and then be able to provide it to them in a seamless way in the EHR. And these panels were utilized to assess in a derivation population of about 30,000 individuals, and then validate that in an initial population of 15,000 to evaluate both prediction of venous thromboembolism and then also separately to predict major bleeding. And we found that we were able to do that efficiently for 90-day VTE, and came up with thresholds of 7 or more for our score for VTE and 9 or more for predicting major bleeding, where we were able to identify a substantial subset of individuals who were at high risk of VTE, but where their bleeding risk was below 1, that might be practical to evaluate for thromboprophylaxis. I'll turn it back to you, Dr. Waller.
Thanks so much, Dr. Horn. This foundational work was really exciting to think about in the emergence of COVID. How might we be able to apply what we learned about among hospitalized medical patients to this unique setting? And so succinctly, the design for this study began with electronic health record interrogation during the height of the first COVID wave, March 2020 through February of 2021. We took all COVID positive patients and then included those individuals that had a CBC and a BMP, which would permit us to calculate their hospital-associated VTE intermountain risk score and hospital-associated major bleeding intermountain risk score if they had those available either 2 days before or 7 days after. We did likewise looking for the presence of D-dimer for our secondary analysis. And we then asked, if we look at the performance of the hospital-associated VTE intermountain risk score and the major bleeding risk score, can we predict who might be at high risk versus low risk for thrombosis? Our cohort overall was over 113,000 patients. Importantly, over 100,000 of those received their testing remotely, largely through a drive-through setting. Another 7,600 were tested in the emergency department, and the minority were emergency room patients. That left us with a study cohort of just over 5,000 that had those CBCs and BMPs adjacent to their COVID test as we described, and 3,100 of those were ambulatory, another 1,800 were hospitalized, and we divided those into patients that required any ICU care or were cared for only on the wards. And what we saw in that study cohort were that first, there were 172 venous thromboembolic events. And when we looked at the predictiveness of the hospital-associated VTE intermountain risk score for the outcome of a venous thromboembolism, we saw that it was effective in predicting risk. And you see the Kaplan-Meier curves here and how they separate, especially within those first 30 days, with the hospital-associated VTE intermountain risk score being predictive of thrombosis, such that in the high-risk group, the VTE rate was 6.7% when compared to 2.3% in those patients that were considered low risk for venous thromboembolism. This is more of a summative slide, and it provides me the opportunity to remark on the other markers, which is the added predictiveness of D-dimer. When we included D-dimer in this model, it improved the area under the receiver operating characteristic curve to 0.76. And you'll see here that the 90-day VTE bleeding predictiveness yielded an AUC of 0.64. One of the novel benefits of this score is that it's derived from only the components of the CBC and BMP in conjunction with patient age. Therefore, a clinician would not be encumbered by requiring medical history to derive this score. And you could envision how that might be applicable in presenting a risk if those components are available in an electronic health record for a clinician to consider. We also understand that VTE risk can be especially helpful in considering in distinct populations, those that are hospitalized versus those that are ambulatory. And this risk score performed well among ambulatory patients, even though the prospective randomized control trial, Active 4B, was stopped prematurely for futility. And I highlighted the value added for D-dimer. So I'll close with our remarks just by saying that these biomarker-only derived risk scores do appear to be predictive of venous thromboembolism and major bleeding among COVID patients. Importantly, others are doing terrific work in this space. Many of you may be familiar with Dr. Spiropoulos' improved D-dimer risk assessment model, which takes into account clinical history as well and is predictive and derived and validated in a similar fashion in a healthcare system not dissimilar from ours. And when available, if we're able to pull D-dimer in, that appears to enhance the predictiveness of the hospital-associated VTE intermountain risk score and to a lesser degree, the major bleeding risk score. So I will pause there and say thank you to you, Yasan, and RPTH for the kind invitation to present today, and we'd be happy to take any questions.
Thank you very much to both of you, Dr. Waller and Dr. Horn, for this great presentation. As someone who's personally interested in COVID thrombosis and risk prediction models, I find your work to be very fascinating and outstanding, which is why I do have some questions that I was hoping to ask you. My first question is, about the utility of the score in the ambulatory setting. And in my mind, this is really an unmet need, since we do have, several major trials on thromboprophylaxis in hospitalized patients, and we have the NIH guidelines now. So we do still need more data on how to guide antithrombotic management in outpatient setting and ambulatory setting. And you did find that your score performed better in that setting as well. So that's sort of exactly what we need. Now, my question is about how the D-dimer levels influence the utility of your score. So you did mention, in your results that a D-dimer of less than 0.5 was associated with a lesser predictability of thrombosis in the HA-VTE IMRS. And in my mind, as a clinician, I tend to think of those in the outpatient setting as probably having normal D-dimers, maybe not necessarily so, but at least compared to the hospitalized patients, I would imagine they're more likely to have normal D-dimers. Does that limit the utility of the risk prediction model in the ambulatory setting?
Yeah, well, thank you very much. And unsurprisingly, you read our manuscript very astutely. It's true, when we looked at the predictiveness, Dr. Horn was able to model how D-dimer could be best utilized and what additional information may be available. And what we observed was that the hospital-associated VTE risk score was most impactful when individuals had a D-dimer between 0.5 and 2. And the way I would think about this is that if that D-dimer is less than 0.5, broadly speaking, that's a patient for whom, if thrombosis risk is considered, might in fact rule out by conventional risk scores. If the D-dimer is especially high, uncertainty exists and further risk assessment becomes likely indicated if thrombosis is a concern in that clinical domain. For us, and what we saw was that this risk score and its predictiveness seemed to be able to best discriminate that middle range, and we think that that's probably impactful because of those patients in our study cohort that had a low D-dimer and a high D-dimer, each were in the minority, whereas 54% of those patients enrolled had a D-dimer in that intermediate range. And so it's a nice opportunity to highlight that more work needs to be done to understand how to apply this clinically, but that D-dimer stratification and its utility is perhaps greatest in those patients that the majority have D-dimer in that intermediate group.
Yeah, thank you. That makes a lot of sense. And I would be curious how many of the ambulatory patients in your cohort had the D-dimer in that range. I'd have to, it might be something worth reporting as a way to kind of elucidate, how many of these patients we could apply the score to. My next question is about, since the pandemic started, there's been a lot of different studies that address predicting thrombosis. Dr. Waller, you recently published with RPTH, about the quality of evidence of the predictability of different biomarkers, and of course, there's been different risk prediction models. And in your paper, you alluded to the improved score as a way of predicting thrombosis. Now, that score is different because it doesn't look at laboratory aspects, more so as clinical history things such as history of thrombosis and immobility and so forth. So my question is, how does the HA-VTE IMRS compare to other scores, such as the improved score? And how would you guide the clinician, who in the hospitalized setting is trying to determine the patient's risk of thrombosis, or maybe perhaps in a different setting, on which score to use and when?
Yeah, thanks for asking. And it's an important question because it gets to kind of the ethos behind Dr. Horn's former research and our collaboration, and that is thinking about surfacing risk in a just-in-time fashion for a provider. And so the value or utility that we see for the Intermountain Risk Score is that it can be calculated in the background and it can be presented as a just-in-time alert should those data be available. You're absolutely correct that if the CBC and BMP are not readily available, then this is not something that can be surfaced readily. However, as you know, in most patients, we see that these are labs that are routinely collected and readily available, and therefore, our thinking surrounds its utility in a systems-based approach where it could be generated electronically and unburden the clinician from needing to go back into the electronic health record and look, for example, at history of thrombosis, actually calculate a score, count points, and the like. And so that's the real incremental advance that we see with the hospital-associated VTE and major bleeding risk scores, is the ability to have those data presented in an actionable fashion.
That makes sense. Thank you very much. Especially, certain things in scores such as, thrombophilia can be different and difficult to interpret, and different people may interpret that differently. So it may lead to heterogeneity in how the scores are utilized. We do actually have a live question from Omar Sabri, who says, does VTE thromboprophylaxis affect the score? Which is a good question, because I don't know whether, the use of anticoagulation or thromboprophylaxis was incorporated in the analysis. Was that something you guys looked into?
Yeah, it's a lovely question, and it's a pragmatic one, right? Insofar as when we looked at these patients, in the majority of those that were included were ambulatory, and the clinical practice was not to provide chemoprophylaxis overtly. In that hospitalized subset, contrarily, why most patients receive some form of thromboprophylaxis during the interval that we did this study, uncertainty existed surrounding the intensity of thromboprophylaxis. So, Dr. Sabri, it was a mixed bag.
Right. That makes sense. Thank you very much. And my last question for you is about the specific variables in the score. And as someone who is interested in risk prediction models myself, I know that a lot of times when these are developed, certain variables make sense. You know how this variable can lead to the specific outcome, and then other variables we try to sort of rationalize as to how that could lead to, in this case, thrombosis or bleeding. And so I did read your original paper where the score was developed to try to see, whether there's an explanation as to why certain variables in both scores came to predict thrombosis and bleeding, particularly ones that are not traditionally things we look at, such as RDW, maybe BUN. I think there was platelet volume in the bleeding model. So have you thought about a pathophysiological explanation as to why some of these variables were able to predict these outcomes?
Well, that's a very good question that speaks somewhat to the epidemiologic nature of this project, where we're going in and we have the data available. We're looking for risk predictors, and so we were going in and deriving the score, looking for anything that would predict the outcome, regardless of whether we could actually upfront describe what the pathophysiological connection was. And so, but in retrospect, as we've seen that not only did it derive with the RDW and the BUN and some of these other factors, but that it validated in other populations. We've thought through, and not just for the VTE prediction, but over the decade and a half we've been looking at it, of what is the implication here? For example, with the RDW, where it's added into the CBC because it has some connection to clinical practice, but not typically looked at by most clinicians. We found that there's a broad ability of RDW to predict outcomes in a variety of different clinical populations. And so it's so broad, actually, that it appears to be an indicator of the underlying health status of an individual, that there are a variety of different processes, both pulmonary and cardiac, heart failure in specific, for the RDW, where people who are less well off, their health is poor, or their health is declining, that their RDW tends to go up. And so it's an indicator of general health status. In this particular area, for predicting VTE, the way that I would interpret it is that biologically, an individual that has a higher RDW, they're not doing as well just in general with their health. And so that potentially puts them at risk because their health is poor, puts them at risk of having a clotting problem.
Quite fascinating. Well, I want to thank you both for joining us today and for presenting your work, truly outstanding work. And I will really look forward to seeing these scores validated in future projects as well. And to our audience, I just want to encourage you all to visit the RPTH website and follow us on social media, on Twitter, YouTube, and Facebook. And for all clinicians and researchers to consider publishing and submitting your work with RPTH. Thank you both very much, and thank you all for joining us.
Thank you.